Now we're going to talk what is probably one of the most challenging topics, but also very important because I'm going to explain to you why things like membrane potential. Yes, I know the cell and molecular stuff tends to be the more trickier and more abstract parts, but it has a lot of consequences and a lot of effects, and it's very important for understanding, especially if you're going to pharmacology. You gotta know how this stuff works, especially if you're going to medicine or nursing too, because you're going to use a lot of these drugs in treating your patients. So this is why it's important to know this stuff. Now let's go on with the heart. So remember my whole analogy with the banana and the ocean. So remember, what is the banana? The banana represents the cell, and the ocean represents extracellular fluid. But we're talking about the heart, right? So we're talking about those cardiomyocytes and the conducting cells and the contractile cells in the heart. So those make up the myocardium, the heart muscle. So again, why am I using a banana? Because again, bananas are chock full of potassium, right? So that's why I have that. And then what is the ocean? The ocean is very salty, so we have more sodium chloride in the extracellular fluid. And there's the seashells that are full and rich with calcium. So that's why I include seashells and extend that analogy a little more. Now, what we have is like, okay, why does that matter? Because what happens if you open up channels that allow these ions through? They're going to flow from the high concentration to the low concentration. And if you wonder what those square brackets are, so if I have those square brackets around something, I'm saying the concentration of whatever's in that bracket. So here we have potassium ions, so I'm saying the concentration of potassium ions is greater inside the cell than outside the cell when the cell is rest. So that means nothing is happening yet. Now, what we have here are all these potassium and sodium. So again, more potassium at rest inside the cell, but there's more sodium and chloride on the outside. But is it in a 1-to-1 ratio? Not necessarily. There's actually a lot more sodium than chloride in the outside of the cell, still more than on the inside, but there's more sodium in general. But you also have inside the cell, you have a lot of proteins, and proteins on the whole. Now, I don't expect you to know which amino acids are positive or negatively charged. You might have to, if you're taking the MCAT, you definitely gotta know that stuff. But that's something that we don't really cover in this class. But take it for my word for it. Proteins as a whole, they can have charges, and in general, inside the cell, they tend to be negatively charged. So this is why the inside of the cell tends to be relatively negative compared to its outside, and the outside of a cell, the extracellular fluid, tends to be more positive because again, it's not a 1-to-1 ratio with sodium chloride. So that's why the outside of a cell, and I'm not even showing the calcium in here, so the outside of the cell has leans more toward the positive ion balance, and then inside the cell tends to have more negative charges than the outside. Now, if you're still confused, I do have a membrane and action potentials refresher playlist, so you might want to look through that. But again, this is different from those neuron action potentials. So now we're going to talk about pacemaker potentials. And these are my little goals here. So what I want you to do is know the differences and so they're very similar. They use a lot of the same vocabulary, but I'll do a little refresher. So if you were here last semester, or if you take AMP1, you probably learned about action potentials, or hopefully you did. If you didn't, then you're kind of done a disservice. But what was happening is that this neuronal action potential, what we have here is that membrane potential. Again, my inexact definition is kind of like the electric charge inside a cell. Now what we see is that it starts off negative, so when a cell is at rest, or a neuron in this case is at rest, it has a negative ion balance relative to its outside. Then this membrane potential becomes positive, then it drops again, and then it returns to its original state. Now, pacemaker cell action potential, it has a similar overall trend. So what we have here is something called depolarization. So we'll notice that at least a neuron at rest, when it's at rest, it has a negative 70 millivolt membrane potential on average. So that means that, but the thing is that it's polarized. Because why? There's an uneven distribution of positive and negative charges on either side of the cell membrane. Same with the pacemaker cells inside your heart. They have an uneven charge or distribution of charges. So again, membrane potential, basically what it does is quantifies as a number. So if it's positive, that means the cell inside is relatively let me rewind. Okay, So it quantifies it, but if it's a positive number, that means the inside of the cell is relatively positive compared to its outside. But if it's a negative number, that means the inside of a cell is relatively negative compared to its outside. So what the membrane potential does is quantifies that and makes it into a number. Now, what causes that? Basically, the bigger the difference between the outside and inside of the cell, the greater, the more, or not to bring up more math, but the absolute value of that number. So the magnitude of that number, if it gets more really negative, that means the distribution is really imbalanced. If it's really positive, that means the distribution is also really imbalanced, but toward the positive side. So this different distribution and this uneven balance is called polarization. If there's no difference in changes or difference in the overall balance, that there's no polarization. But as long as it's toward the negative, it's polarized. Now, this is this is why I think it's a lot of technical stuff. I don't expect you to know the physics version of this, but what you should do is, this is why I think when you're starting out, this will get you through a lot of this action potential stuff. So again, do not carry it to other classes. Now, this is what I try to break it down with action potential. So I'm like, what is this action potential? You keep talking about this electric activity. Well, this is what happens when you have an action potential in a cell. So in general, this applies generally to all types of cells that can have action potentials. Once its membrane potential reaches a certain number or certain voltage, then ion channels open and close. And that's why it's important to know where those ions start off with. Because again, ions in facilitated diffusion, they'll move from high concentrations to low concentrations. So just knowing where they start and where they're stacked up on either side of the membrane, that will save you a lot of brain power in knowing which ones open and close and which way the ions move. So what happens when these ion channels open? Well, now the ions have a difficult time crossing the plasma membrane of a cell by themselves, but once you open a door for them, they can flow through via facilitated diffusion. Then what happens is that, remember that ions either have a positive or negative charge. So remember that membrane potential has to deal with positive and negative charges. So if you start altering the balance of positive and negative charges inside a cell, that is going to change the membrane potential. And there are big changes, and that's why you see that graph swinging up and down so often, because of these changes in ion movement. So an action potential, basically what it is, depending on the cell type, so we covered neurons last semester, now we're talking about cardiac action potentials this semester, it's the sequence. So it's not just totally random. There is, in the normally functioning heart, there will be a sequence of these ion channels opening and closing, and a sequence of these ions moving. So it's kind of like it's like doing a dance or something. Like there's set pattern dance, where it's like, okay, you have these steps to the dance, and it's always in these orders if you're doing the same dance over and over and again. Same with these action potentials. They're doing the same thing sequence over and over again. But instead of doing steps like dance steps, it's the ion channels opening and closing. Now, again, this is why it's important to know where they start, because if you open these channels, it's going to flow from high concentrations to low concentrations. So for potassium, open up a potassium channel, it's going to flow from the inside of the cell and go to the outside of the cell. So this is called efflux or efflux, but I'll say efflux to emphasize it starts with an I. So, or not, starts with an E, I'm getting ahead of myself. Okay, so then efflux is going to make it go toward the exterior, so potassium channels open. The potassium is going to leak toward the outside of a cell. Now, everything else, sodium, chloride, calcium, if you open any of those channels, or if you those respective channels, sodium is going to flow inside the cell, chloride is going to flow inside the cell, calcium is going to flow on the inside of the cell. Now, this is the big difference between, and if you thought neuronal action potentials were difficult, calcium action potential or cardiac action potentials are actually more complex, because calcium wasn't as much of a factor in the action potentials in neurons, but now they become more important in the heart. So this is my main thing. So the thing is that these action potentials in the cardiac cells, they're different from neuronal action potentials, but some of the vocabulary still stays the same. Influx, efflux, and we also have, polarization. depolarization, repolarization, and thresholds. And membrane potential still same definition overall. But the big difference between one and the other thing is that there are multiple types of action potentials within the heart, depending on the cell. I'm not going to expect you to know all of them, but I want you to know the pacemaker ones and the ventricular ones. Now, what we have here is that the cardiac muscles can trigger its own action potentials. Again, with that video of showing the heart beating by itself, that autorhythmicity, this is one thing that makes cardiac muscle action potentials very special because they can set themselves off. They don't need, if you remember things with like the skeletal muscles, what you need is a motor neuron, and it innervates and then releases acetylcholine onto a skeletal muscle fiber, causing it to contract. Well, you need that neuron because if you have a lesion or something that damages or denervation of that muscle, you can't control that muscle and you can't trigger that contraction anymore. But cardiac muscle is special because it can contract without the presence of a neuron. But again, this is another thing about the conduction system. It is not made out of neurons, but specialized cardiomyocytes. How are they different from your regular muscle cells? Well, these specialized conductive cells, they have fewer of those like actin and myosin, those contractile proteins that allow skeletal muscle to contract, and they're more specialized, so they're going to have less actin and myosin and more of these ion channels and more of these gap junctions and proteins that allow ions to move in and out of cells. I know, that's a lot. Okay, now let's go back to this graph. So this is what a pacemaker action potential looks like. We're actually showing like about actually 2 cycles of it. So what we notice is that there are phases that are color coded here. I'll walk you through the phases. Now notice that unlike a neuron, it doesn't quite stay at rest for a long period of time. And why is that? Well, your heart is constantly beating in your chest, right? So that's why you need this pacemaker cells to constantly beat and constantly do this rhythm. That's why even though it reaches this minimum, it never quite stays there. So yet another difference between that and a neuron. Now again, remember that membrane potential when you're at this part, so notice that this is the 0 over here, and this is a negative cell membrane potential. So the more you go toward this side, the more negative it is. And when the more it's down here, that's what you call polarized. But when you go up here and go past 0 and now you're in the positive, you're undoing the polarization, and that's what we call depolarization, when you go from here to here. Now, cells in general, they have negative membrane potential, so it is technically polarized if you're in the positive. But since most cells are in the negative membrane potential, this is why we call it depolarization, because it's polarized as long as it's not 0. But when you undo it, it's depolarization. Okay, back to our pacemaker potential. So what we have here is a slow influx. So that means sodium is coming in. Why? Again, this is why I have that analogy. Sodium starts at a higher concentration on the outside, and then inside the cell, less. So sodium is going to flow into the cell if you open these channels. Now, what happens is it reaches this certain number, this certain voltage called a threshold, and then you have the action potential. So this little spike here is so similar, not quite exactly the same, but the action potential, what you see is a big jump toward the positive and a big jump toward the negative. That's the action potential in the SA node. Now what this is called a pre-potential. So when you're going from this minimum here to this threshold, now do I expect you to know the exact number? Depends on your textbook, and OpenStax it says that it goes from -60 to -40. I think it's more about knowing that it does start to the negative, and it does go up toward the it starts at pacemaker cell at rest is at the negative membrane potential, but when it's doing this pre-potential, it has to get slightly more positive. So another analogy I like to use is like, say this is your credit card bill, and you're -$60 in debt, and then what do? Maybe you say, okay, every day I'm gonna put $1 more, $2 more in my credit card toward my paying off my bill. So what happens is that you have less of this negative balance. So if you add positive income to your payments toward your credit card, you're going to creep toward the positive side. So you still have a little bit of debt, but now you're at this certain number we call threshold. So what we call this process of going from this minimum to this special number we call threshold potential. This is what we call the pre-potential. So the interesting thing is that these pacemaker cells, they're actually able to do this by themselves, and it's due to a slow influx of sodium. So it's like those little dollar bills going toward your small credit card debt. Now, what happens is that these action potentials do not occur until these reach that threshold. So again, that big jump toward the positive and then down toward negative, it doesn't happen until you actually reach that threshold. So threshold is some sort of membrane potential. It's a set number where we need to start an action potential. And how does that happen? Well, it has to deal with those ions and those ion channels. Now, the pacemaker cells can contract by themselves, and then when they reach this threshold potential, that's when we get those action potentials. So that threshold potential, once you cross there, you get that jump up toward the positive, and then what we call repolarization, because now you're going from this around zero, or actually you're just actually starting from the positive, but you're going back to where you started. So remember, like these cells, when they started, they were in the negative. So they were polarized. So by going back to that polarized state, you're repolarizing the cell. So, and then what we see here is that the whole cycle repeats. So what we have is a slow pre-potential, action potential. Slow pre-potential, action potential. So that's how these pacemaker cells work. Now you might be like, okay, how the heck do they do that? And what's all this ion stuff? So what we have here is something called a funny current, and it is a type of, if you remember here, like the nervous tissue chapter from last semester, so it is kind of a leaky channel in that it's always kind of open to some extent. So what it does is kind of like allows these ions to leak. Now I don't expect you to know, or for this part, what I want you to know is that this funny current allows sodium to flow in because again, why? As a cell at rest, there tends to be a higher concentration of sodium on the outside, and it does allow potassium to leak out slightly, but that's like more advanced stuff. I don't expect you to know that part for this class, but I want you to know the sodium part. So the sodium is going to go in, and yeah, there is that potassium, but you can ignore it for the intents and purposes of this class, because why? Overall, you have more movement of sodium into the cell through these kind of funny currents that leak in sodium slowly into your cell. So sodium ions are positively charged. But remember that our cell started at a negative charge, right? So if you start at negative and start to add slowly positive charges, and so just like your bank account where you're slowly adding positive income to your bank account or a credit card, that's going to move it toward the positive. Now, at the certain midpoint between and I don't expect you to know the exact midpoint, but along the way, that's all I want you to know. Along the way, then these other channels open. So it's actually not just sodium. Calcium channels also open. And I don't expect you to know the T-type. The med students have to know this stuff, but I like to describe it as a slower calcium channel. It's a different calcium channel from what I'm going to talk about in the next slide. But what is a calcium channel, and then right now it's closed. But once you reach this point, that's along the way between that minimum and that threshold, this is it's a voltage gated channel. So if you don't remember what voltage gated means, it's kind of like a combination lock that opens with a certain number. Same with these voltage channels. They only open at certain range of voltages. So once it reaches this range, it's going to open these channels. And remember that at rest, we started with more calcium on the outside. So if you open these channels, calcium is going to flow in, that influx. And what is that going to do to the membrane potential over here? Notice that these calcium ions have a +2 charge, right? So these are positive ions coming in. Which way will the membrane potential go? Alright, we got a lot of votes, so let's see. Most of you said, around 80% of you said positive. So what we have here is that, yes, it will go toward the positive, because why? We started adding positive ions to the inside of our cell. Remember that membrane potential is all about the inside of the cell, right? So with this additional boost of calcium, we have sodium flowing in, but we also have calcium going in. So this is why the membrane potential is going to go, this is going to give additional boost of this membrane potential toward the threshold. So what we have is an overall increase in these positive, what we call cations, And these cations are going to make the membrane potential go up because why? They're positively charged. So you're going to bring the negatives, initially negative cell membrane potential up toward the positive side. Now, what happens is that now it opens up a different type of channel. And again, this fast is not actually a real like accepted term for that. The L type is like, I don't expect you to know that because again, that's a little specifics. What I want to appreciate is that it's a different type of calcium channel. Because why? Well, when these calcium channels, these open in response once you reach this threshold potential. So this threshold potential is when these different types of calcium channels open. So once we reach this threshold potential, calcium channels open. Which way will the calcium move? It will flow from high concentrations to low concentrations, right? So what we have is a huge rush of +2 calcium ions into the cell. What is that going to do? It's like when you have your bank account and then you have your paycheck hits. So what happens is that you're going to have a huge increase in membrane potential because you have this mass amount of calcium ions that are +2 charge going entering the cell. So this is what causes that membrane potential to jump toward that positive. So that's why we have that sharp increase. Now, what's going to happen is that once you reach it, it actually overshoots 0 and ends up around, again, I don't expect you to know the exact numbers, just know that it is in the positive and it's not 0. But what we have here is that this positive around +20 in this diagram over here, once it reaches this membrane potential, once at that +20-ish, it's going to open these potassium channels. Now these potassium channels, when they open, well, what's going to be the consequence? Well, they're going to allow potassium. Let's ask another question. Which way will potassium go? And I would use top hat, but it's funny, like I got a little top hat error. I'm like, okay, I'm not gonna try to get this fixed. I have a lecture to give. Alright, so again, this is where we are in the story. This channel was closed, but now that we've reached this positive membrane potential, these channels open. Which way will potassium flow? Will it go inside the cell or will it go toward the outside of the cell? So I'm going to end the poll. Seems like around 60-ish of you said that it will go toward the outside, and 30 and 40%-ish of you said it will go toward the inside. Remember, this is why it's important to know where they start, because actually we start out with more potassium on the inside. Therefore, if you open up a potassium channel, this is going to cause potassium to efflux and go toward that exterior and extracellular fluid surrounding the cell. Now, what is that going to do to your membrane potential? So again, the potassium ions, they have a positive charge, but now they're leaving your cell. So again, if we're using that bank account analogy, if the cell is your bank account, it's like you're having to pay your rent. And then what happens is that you have all this stuff that was positive in your account now leaving your account. So what happens to your overall balance? It goes down. Same with the membrane potential. So the membrane potential is going to go down toward the negative. This is what we call repolarization because again, polarized is where we started, but now we're going back toward the negative. So again, this is my analogy is like, okay, depolarization is you get your paycheck, but now you have to pay the rent. So that's the repolarization. Okay, so this is yet another analogy. So if you've ever seen one of these, like in a Zen garden or Japanese garden, or if you played Animal Crossing, they call these things a deer scare. I love these fountains. If I had a backyard, I would totally have one of these. So my analogy is that what you have with these little fountains is that they're filling up this, like pretend this is like a pacemaker cell. And what happens with these fountains, notice that they always fill up and fill up, fill up, and then they tip over and make a little dunk sound, right? So they make a little bonk noise. When they make it rhythmically and they fill up, fill up, fill up, and then they tip over, make a bonk noise, and then fill up, fill up, fill up. So it repeats over and over in a rhythmic fashion, right? So pacemaker cells are kind of like that. But instead of filling up with water, what you have are sodium and calcium. And those two, they're going to make it go to push a pacemaker cell. So when you have this rush of sodium and calcium into a pacemaker cell, that's going to trigger an action potential. But remember, with that sequence we just talked about, it undoes it, and when it repolarizes it, now the whole process has to start over again. So this is why I like to say, just like how pacemaker cells, they maintain a constant rhythm in your heart, This is how the sodium and calcium ions help to maintain that rhythm. So this is why we see if you have these pacemaker action potentials, they have that pre-potential, then depolarization, repolarization, pre-potential, depolarization, repolarization. So just like that little deer scare fountain, it's able to maintain a rhythm and with this repeated action over and over on a constant pace. Now, why does that matter? Because if you have things like hypercalcemia, and that's what a big difference between cardiac muscle action potential and a neuronal action potential is the calcium, right? So if you have hypercalcemia, that's going to affect multiple phases of that sequence of ion channels and the rate at which these ions flow into a cardiac muscle cell. So if you have abnormally, what's hypercalcemia? So hyper, again, if someone's hyperactive, they're like really full of energy and they're overactive, right? So same with hypercalcemia, that means you have abnormally high blood calcium levels in your body. And what they can do is cause arrhythmia because now you're kind of like turbocharging the action potentials and the pacemaker potentials because why? That pre-potential that goes to threshold, that involves calcium. That depolarization also involves calcium. So you're kind of speeding and turbocharging that part. So it can cause arrhythmias and that can cause irregular heartbeats because why? Now you're kind of messing up that process. Hypocalcemia, if you have very severe levels of that, that can cause, then again, hypo is opposite of hyper, so it's going to be low, abnormally low. This can lead to heart failure because why? Well, notice that we need calcium at multiple phases of that pacemaker action potential to actually push that cell toward the threshold, but also carry out the action potential itself. So if you don't have enough calcium and you don't have enough calcium flowing into these pacemaker cells, you're going to mess up their function and also maybe not generate enough heartbeats and enough contractions to actually pump blood to the rest of the body. And this is why the conduction system is very important because these ions this is why because these pacemaker cells, and actually pacemaker cells are all over the heart, but the biggest concentration center of these pacemaker cells in the SA node. So this is what's able to kind of spread these ions and these electrical action potentials. So just like neurons can spread action potentials to other neurons, same with these pacemaker cells and the conductive cells of the heart. They can spread these action potentials among each other. And this is why with this SA node, if in a normal functioning heart, is that due to the pacemaker cells doing the action potentials rhythmically and constantly maintaining that beat, that's why we have a constant cardiac cycle in a normal heart. All right, back to the heart. So again, does this mean the heart is completely independent of the brain? So does that, well, can the heart beat without the brain? Yes, as we saw from that video, yeah, it can beat without the brain, but is it completely independent? No, so the brain can alter the heart's activity. So the brain can change how fast and strong the heart can contract. So it can modulate, it can speed up the heart, and it can also slow down the heart as well. Now, with the sympathetic nervous system, remember that sympathetic nervous system, very important in terms of exercise and dealing with that stress response. So what happens when you have sympathetic activation in your body? What happens to your heart? You might notice that it kind of feels like it's pounding in the chest, that your heart is beating harder, it's beating faster. So that's due to the sympathetic nervous system. Now, what happens is that we have the primary one is beta 1. There's beta 2 as well in the heart, but beta 1 is the primary one in the heart. Beta 2 is more if you're going into like med school, you have to kind of know that. But what they do is that when you have sympathetic activity and the sympathetic nervous system releasing epinephrine and norepinephrine onto the heart, that is going to activate these adrenergic receptors. When you activate those receptors, that's going to increase the sodium and it's actually going to open up those channels, even more of those channels, and increase the rate of how sodium and calcium flow into the SA node. So what happens is that this is why your heart rate increases. To do it visually, here we have our funny current and our fast calcium channels. So this is how it would be normally, and this is why we have our action potentials like this. So we have sodium, we have those slow calcium channels as well. This, once it reaches the threshold, now it opens these fast calcium channels that cause depolarization. Then we get the repolarization, wash, rinse, repeat. But if you add sympathetic activity to that equation, what you have is you release norepinephrine onto the heart, and it's going to bind to these beta receptors on the heart, and that's going to cause these channels to even open up even more. So what you're going to have is even more sodium flowing into the heart, and then you're going to have even more calcium flowing into the pacemaker cells as well. So what's that going to do? Well, it's going to actually make it push it toward that threshold even faster. So this is why you have this. So notice that compared to how we had it originally, it's a shorter time and the slope is going up even more steeper. Why? Because now we're getting more sodium and calcium flowing in at a faster rate. So what we see overall is that now there's a shorter time for each action potential and pacemaker potential in a pacemaker cell. So now you can fit more beats per minute and you can increase your heart rate because why? You're shortening that time to that threshold. So this is why and it's not just your sympathetic activity. What if you give someone an injection of epinephrine? What is that going to do to their heart? It's going to cause the pacemaker cells to kick up their action. Why? Because of this mechanism we have right here. And there's also something called calcium channel blockers. Do I want you to know this specific one? Maybe just a category. So calcium channel blockers, this is just one example. But what are they going to do? Well, block calcium channels, right? But why does that affect the heart? Well, that pacemaker potentials. Remember that calcium is involved at multiple phases of a pacemaker action potential. So what they do is sometimes, like if just like when I speak and sometimes I talk too fast and I tripped over my words, same with these pacemaker cells. If you have like if they start being too fast or they're irregular, sometimes if it's when they're at having these arrhythmias, that means they have a normal rhythm. You don't want them to keep on going on, and maybe you want them to pull back and slow down a bit. So this is one potential use of these calcium channel blockers. So why? Because we have the calcium depolarization over here. So what you can do is actually slow that part down. So what we have is this rapid influx. But if you have these calcium channel blockers, what they're going to do is slow it down, block some of these channels. So instead of having that sharp jump up, now it's going to be prolonged and slow down. And that's going to slow down your heart rate overall as well, hopefully allowing your pacemaker cells to recover. So that's why the ion movements are very important, especially for pharmacologists and medicine, because you have a lot of drugs that affect these channels directly, and this is how you can help regulate the heart. Okay, so now how do they trigger the rest of the conducting system? And again, the conductive system, what we have here is the SA node and have the signals spreading from the SA to AV, bundle His, bundle branches, and the Purkinje fibers. Now let's look down to the cellular level. At the cellular level, this is a cardiac muscle cells, actually multiple of them joined together. And are there drugs for hypertrophy? Yeah, so there are drugs, and you can also do drugs. You can also do nutrition if it's not an acute one, or you can just do an IV. So it's like multiple routes you can do to supplement calcium. So that's also why, hey, nutrition majors, it's important to not calcium is good for bones, but you don't want to be deficient in calcium, but you also don't want too much calcium as well. Calcium channel openers. So yeah, you can look that up too. So these are things that increase calcium influx. So that's the cool thing about pharmacology. Often you have things that do the opposite. So sometimes you have to give an antidote to something. Sometimes it's a direct antidote. Sometimes it affects something else that affects it. Like remember that parathyroid hormone, calcitonin, those hormones, that can also affect calcium as well. But back to cardiac muscles. So now we went from the heart and these conductive cells. Now let's look at the cardiac muscle cells themselves. Now if we look at this, we have these intercalated discs that join cardiac muscle cells. And what these intercalated discs, they have many things and that attach them. So they're there for structural integrity and gluing these cardiac muscle cells together. But they have these very important protein channels called gap junctions. And gap junctions allow very small molecules to flow between the cytoplasm of connected cardiac muscle cells. So what they can do is allow many things, including ions between the different so they can allow ions to flow between adjoining and adjacent cardiac muscle cells. So that's what we have here going. So if you have a big influx of sodium in one muscle cell, so that's what we're seeing here. Say this one is a conductive cell and it does an action potential and has all this sodium and calcium flowing in. Well, all this sodium, now if this cell now has a higher concentration of sodium and or calcium than the surrounding cells, these ions can flow to the adjacent cells, and they can set off their own action potentials along the membranes of these cells as well. So this is why these action potentials and this movement of ions overall is able to spread across the entire heart because of these gap junctions. And that's why gap junctions, even though like yeah, they're more just something that joins cells together. They're very important for how the heart is able to pass signals from one cell to another cell. And there is more. So there are different types of cardiac action potentials. So we just covered the pacemaker ones and the SA node. The AV nodes, they're very similar. I don't expect you to know the difference. There are Purkinje action potentials, but I don't expect you to know that. Now the atrium, instead of conductive cells, we also have contractile cells. These are the ones that actually do the heavy lifting and change the shape of the atria and ventricles. So the atrium and ventricles have a different shape to their action potentials. So it's different from the SA node and the pacemaker potentials. Am I going to ask you the difference between atrial and ventricular action potentials? No, I think that's more for advanced physiology or for graduate or medical school. But I'm going to just cover ventricles because, again, those are the ones that do the heavy lifting and pumping blood to your lungs and also pumping blood to the rest of your body. Now, these are the phases. So this is one thing that makes it different from, pacemaker cell, is that cardiac muscle cells, they do have that downtime. They can relax. Versus pacemaker cells, they're always kind of bouncing and doing pacemaker potentials all the time. Ventricular cardiomyocytes that contract, they relax because again, you need that diastole, right? So what we have is that its resting membrane potential is pretty negative toward the negative 90 millivolt side, but it has a rapid depolarization. So this is something you see once it reaches threshold, and that's what we have here. You have a depolarization. So depolarization, and notice that just like a neuron is going to open these sodium ion channels. So if you open up sodium ion channels, remember that sodium starts off higher concentration outside of the cell and it flows into the cell. So that's why we have this big jump toward the positive at the first part of a ventricular cardiomyocyte action potential. Then what happens is that once you reach here, remember like in the neuron and the pacemaker potential, once you reach that positive number, those potassium channels open. And what would happen is that it would plummet back down toward the negative. But this is where ventricular cardiomyocytes are a little tricky. What happens along the way is that calcium channels open. So now you have potassium that's positive leaving the cell, but you have calcium entering the cell. So this is why we have something called the plateau. So we have positive ions moving, but some are moving on the outside, but some toward the outside, some are moving toward the inside. So because calcium is moving toward the inside and potassium are it's like those two ships passing, or I should create that. I should create a meme for that. But have you ever seen that Umbrella Academy when they're kind of passing each other and they kind of give each other eyes? Like calcium and potassium are like that. They're kind of passing each other and they're kind of like, wait, yeah, I'm moving in, but you're moving out. But because of that, overall, they're both positive. That's why we have that plateau, because it's not going to drop either way because we have positive ions both coming into the cell and leaving outside the cell. So it's kind of like when say you have a side hustle or you have a Fiverr account, and then your slow trickle of money in is also counteracting your avocado toast and and Starbucks. So the small little expenses are also counterbalancing your small income as well. That results in that plateau. Now at this point, once it will drop eventually, and then these calcium channels close. So now but these potassium channels are still open. So remember that potassium wants to leave the cell. So the potassium, by leaving the cell, is going to repolarize, because why? Now it no longer is counterbalanced by calcium. Now with potassium being able to leave the cell, that's why we get dropped back toward the negative. Yeah, so now the calcium channels, or not calcium, potassium channels are still open. And then we're back to that resting membrane potential. So that's the big difference. And again, yet another reason why calcium is very important for the heart. Now, what happens is that these conductive cells, so again, we have that conducting system, so all the cells can pass these signals on to cardiomyocytes. How do they do that? Those gap junctions we talked about earlier. So what we have are those calcium and sodium ions. They can be passed from conductive cells to cardiomyocytes. This pushes cardiomyocytes toward that threshold potential. And when you push a excitable cell to a threshold potential, then you can do that action potential, right? So that's what happens with the cardiomyocytes. By these conductive cells passing along their positive ions, they're able to set off these cardiomyocytes and set off trigger action potentials in these cells. Now, remember that plateau? That plateau we just talked about in the previous slide has calcium moving in. So when you have calcium moving into a cardiomyocyte, what's going to happen if you have all these action potentials spreading among this cardiomyocyte, you're going to increase the intracellular concentration of calcium. But it also does something else. There's something called the sarcoplasmic reticulum, and this is like the one in skeletal muscle cells. The sarcoplasmic reticulum is a fancy name for this endoplasmic reticulum in muscle cells, but it's more than just an endoplasmic reticulum. It's also an important storage area for calcium. So action potentials, when they approach and they're near these channels on the sarcoplasmic reticulum, these channels are actually calcium channels. So when these action potentials are buzzing near these sarcoplasmic reticulum channels, the calcium is released toward the inside of the cell. And now what do we have here? We started over here, not too much calcium here, but by all the action potentials and triggering the release of calcium from the sarcoplasmic reticulum, now we have a huge increase in the concentration of calcium inside a cardiomyocyte. Now, what's that going to do? Hey, flashback all the way to skeletal muscle. Now, this part is the same in terms of how actin and myosin interacts. Remember the cross bridge cycle and how you need calcium to move so you need like tropomyosin and you have troponin and tropomyosin, and that troponin needs calcium to move tropomyosin away from actin, and now actin and myosin combine, all that good stuff. Basically, you need calcium for contraction. That's the end point of that. So by having all this calcium released to the inside of a cell, what this allows is it allows your fibers, those muscle fibers, or those myofibrils inside these cardiac muscle cells, now they can contract, now myosin can pull actin, and now you can have a contraction of this cardiac muscle. So again, this is why calcium is very important for muscle cells. Okay, so let's see. I don't know if I have enough time to talk about EKGs and heart rate in 2 minutes. Thanks everyone. Thanks to everyone, and have a great weekend. I wish it was another 3-day weekend, but hey, hang in there, and we'll cover EKGs next on Monday.